This is the AAO mini seminar on adult laryngotracheal stenosis. I'm your moderator, Radhamadhab Sahu, and I'd like to start just by a few housekeeping matters. Of course, is shutting off your cell phones and putting them on vibrate so that they don't interrupt the speakers. We have a great panel for you today. I'm going to start by introducing the faculty. We're going to start off with Catherine Linsnick, who's an assistant professor at the Wake Forest University School of Medicine. She's done some wonderful work with the in-office treatment for laryngotracheal stenosis and is going to be sharing some of that with us. Next up, Dr. Albert Murati, who certainly needs no introduction. Well known, I think, is infamous now for being on more mini seminar panels than anyone else, including 2 simultaneously on Sunday. But Al is going to be talking about open procedures for the treatment of LTS. And last but not least, down there, Dr. Kevin Leahy, who is an assistant professor at the University of Pennsylvania. He's a graduate of the Hopkins Laryngology program, as I am from way back. Has an interest in the molecular basis of laryngotracheal stenosis, and he's going to be sharing some of his pioneering work with us. So we're also going to have, by the way, a panel discussion in the end to talk about some cases that will run by the panelists. So without much further ado, I'll go ahead with our topic. I'm going to start off by setting this up here. So certainly, laryngotracheal stenosis is not a new problem. This is a problem that's been around for a long time, which unfortunately still exists today, although with different etiologies. So in the early 20th century, the most common etiologies were infectious, so TB and diphtheria. In 1917, Chevalier Jackson brought attention to the high tracheotomy as an iatrogenic cause. And for the most part, these two, all the way up until World War II, were the most common causes. So World War II, you have a lot more cars on the road now, a lot more motor vehicle accidents, a lot more laryngeal trauma, and the so-called padded dash syndrome, where the larynx is crushed against the dashboard. 1970s, you have endotracheal intubation, of course, produced many, many survivors from bad respiratory illnesses, but unfortunately also produced a lot of these complications. 1980s, 1990s, the advent of these mini bikes, snowmobiles, all-terrain vehicles, a lot more laryngeal trauma still, and particularly more of the laryngotracheal separation type injuries. So anatomically, the relevant anatomy, of course, is that of the larynx and the upper trachea, and just like as we do for oncology, it's divided into supraglottis, glottis, and subglottis. And in terms of classification, there are a variety of different ways. You can certainly classify it as acute versus chronic. We can classify it as congenital versus acquired, but really a much better system that I find in the adult is anatomically by site. So we can classify glottic into anterior, posterior, or complete. You have subglottic, upper tracheal, which can be anterior or circumferential, or some combination of the above. Now, this staging system was proposed by McCaffrey in the early 1990s, and I still find it very useful. The reason is, in his series, and I concur certainly from my experience, that he was able to predict outcomes and the likelihood of a good outcome based upon his staging system. So stage 1, you have patients that have a small lesion here, less than a centimeter, usually membranous, confined either to the subglottis or upper trachea, and 100% of his patients with this were able to get decannulated. Stage 2, you have a lesion that's more than a centimeter but confined to the cricoid ring. And still 95% of those patients did quite well. Now you get to stage 3, you have greater than a centimeter extending into the upper trachea. Still 90% were able to be decannulated. Now contrast that with stage 4. The minute you get involvement of the posterior glottis, either with fixation or paralysis, decannulation rate goes down to about 50%. And so the take-home message here certainly is that once you get the glottis involved, the outcomes are not as good. So this is a table of etiologies, and still the most common reasons today are endotracheal trauma, whether it be from intubation alone or tracheotomy or some combination. Above this is a series from the University of Mississippi, and about 60% of the cases were endotracheal trauma. In our series from Temple, we had similar kind of results. External tracheal trauma or laryngeal trauma, another 10%, and neoplasms, about 23%. And you also, of course, you have the idiopathic group. So a more comprehensive list of the etiologies, however, should always include the chronic inflammatory diseases, so sarcoid, TB, Wegener's, relapsing polychondritis and the like, and also the bullous diseases, cicatricial pemphigoid, and I've had certainly some cases of this causing stenosis. So the basic pathophysiology for external laryngeal trauma is going to be, of course, when the trauma causes disruption of the framework, the cartilage gets fractured, you get hematoma, just like you can get a septal hematoma. When that hematoma resorbs, the overlying cartilage is usually resorbed, it's replaced by collagen, it's scarred, it then contracts. And because the trauma can be anywhere, the injury and the lesion can be anywhere. Now contrast that with the injuries that you see from endotracheal intubation. They're usually pretty typical locations, either in the posterior glottis where that endotracheal tube is sitting against, or in the upper trachea where the cuff is causing injury. And this is almost always an ischemic type necrosis from too much pressure. You get ulcerations, it gets infected, then you get underlying infection, you get perichondritis or chondritis, and then fibrosis, which then contrasts. So most often these patients will present with some history of laryngeal insult, whether it be intubation or trauma. Then they'll develop progressive hoarseness and progressive respiratory difficulty, and then eventually stridor. And certainly in the acute cases, you have to be hypervigilant because most often, they're not going to come in with a diagnosis, and more importantly, people are going to try to send you the wrong way. They're going to tell you, this is asthma or this is vocal cord dysfunction. And you really have to be hypervigilant based upon their history that, hey, this is a person who may very well have laryngotracheal stenosis. Now, in the chronic situation, most of those patients will come to you prepackaged and have a trach already most often, and diagnosis maybe in scans. And for those patients, we'll work them up pretty methodically. So with office endoscopy, imaging, flow volume loops, laboratory evaluation is necessary, and then OR endoscopy. And we'll talk about each of these in turn. So office laryngoscopy, this is a typical example here of a patient that came in. This patient underwent thyroidectomy, and when they were doing the thyroid, they noticed the anesthesia had a little bit of difficulty passing the endotracheal tube. Now, interestingly, she had a history of Wegener's already, but had not had any upper respiratory symptoms at all, and had been pretty quiescent. And then you look down here, you can see the intubation was a little traumatic on the left, and you can see the narrowing subglottic. Radiographic workup, for the most part, CAT scan is going to be the most widely used study. It's fast, and all the others here really I mentioned more for historical purposes, whether it be plain films or zero radiography, which is this high kill voltage technique. For tomograms, almost nobody even does, and MRI is just too slow for these patients. So CT is really pretty much your best friend. And especially with the multi-detector technology, you can reconstruct the airway in 3D, as you can see here, and get some really incredible depictions of what's going on. I'm going to blow through these pretty quickly just in terms of time. So flow volume loops are pretty much the single best pulmonary function test that you have. We have some data, of course, way back from the late Dr. Kashima with his papilloma work in terms of what's acceptable in terms of airways. But it's useful, the way it's done is that the patient is asked to inhale deeply all the way to total lung capacity, and then forcibly exhale, and this is usually done 3 times. And this is the typical kind of cookie cutter pattern that you get in somebody with stenosis, and that both the inspiratory and the expiratory phases are both blunted. So we do almost everyone, although not always, most people we take to the operating room for endoscopic assessment. So when we're looking there, we're looking to see what the length, the width of the stenosis, is it soft, is it fibrous? We measure its distance from the true vocal folds. We evaluate arytenoid mobility, and we always photograph and video document. Not uncommonly, these patients come with lawyers attached to them, whether it be from motor vehicle accidents or whoever else they're suing. So this is a typical example. So we have somebody suspended here. You can see we've got this scarring. The whole right vocal fold pretty much is replaced and gone. Narrowing in the subglottis as well. And then another example here, let's see. Well, we'll put in another one here. Again, somebody shipped in from another institution, bad lung disease, and very noisy breathing. We look down, he's got, again, 2 layers of narrowing in his